Hello, and welcome to another episode of No Notes, where the conversation is always a perfect 10 out of 10. This podcast is powered by Eleos, the most used and most loved AI platform in behavioral health, equipping more than 130 organizations and tens of thousands of providers with powerful automation tools that streamline documentation, simplify compliance, and surface deep care insights that drive better client outcomes. I'm your host, Dr. Denny Morrison, and for today's episode, we are excited to be joined by Katie Weihe, Human Services Vice President at Aurora Mental Health, and Amanda Rankin, Customer Insights Lead at Eleos. We'll chat about the challenges many behavioral health leaders face when trying to assemble competitive staff compensation packages and some creative strategies for attracting and retaining top clinical talent without breaking the budget. Welcome, Katie and Amanda, and thank you so much for being here today.
Thanks for having me.
Thank you.
Well, start with Katie. Why don't you tell us a little bit about? We had heard your title, but tell us a little bit about what you do and what your background is, Katie.
My name is Katie Weihe, and I have worked in healthcare for over 11 years, but I've worked in HR for over 20 in various industries. And I work in all aspects of HR, whether that's compensation or strategic planning, organization development, but do all things related to engagement to attract and retain employees.
Great. And Amanda, tell us about you.
My background is I'm a licensed clinical social worker. I've worked in community mental health organizations for 20 plus years. I've been the therapist, I've been the manager, I've been the director, and I was most recently the COO at a community mental health center in Chicago, where I was introduced to Eleos for the first time and became a design partner for what has since become their mobile platform. So I'm sure I'm going to be talking quite a bit about that experience as we talk about the challenges of compensation in these spaces.
Yes, we shall. Um, but let's start about kind of the big picture. What do you guys see as some of the more notable trends you're seeing in provider compensation, especially in the community behavioral health space?
I think I worked in a hospital during the pandemic, and we saw things with compensation that we have never seen before. You've heard of the great resignation. We had so many people that would leave for travel assignments. So, compensation was actually really put on the forefront during the pandemic. And at that time, there's a lot of focus on nursing. But since the pandemic was over, I think that has really shifted to mental health. And I think that there's some catching up that we're doing to see because this work is so important and thrust in the middle of the America's spotlight. And so doing what we can to make sure that these providers are getting paid what they're worth is huge.
And so, when you mentioned like people going to travel assignments, meaning like locum tenens and private
Exactly.
duty nursing and things like that,
Exactly. With huge contracts that you just can't compete with because the money was just insane.
Amanda.
Yeah, I mean, similarly, prior to the pandemic, I think that the industry had been neglected for a long time as far as compensation was concerned. And when a when a clinician is paying $100,000, $200,000 for their education to get a master's degree, and then thrust into a space where they are barely making ends meet and can't pay for the debt that they are in from their degree, it makes it really hard to attract and retain talent in community mental health when you're doing a very complex and difficult job with a difficult and challenging client population. So, I think that was we started to get some attention during and after the pandemic as far as like the importance of pay equity and compensation. But I think we still had long way to go. And I'm really hoping that we don't start to backslide at this point.
Oh, is there something unique about community behavioral health and their compensation structures that makes it uniquely difficult?
Um, yeah, I think so. I think that a licensed social worker going to work at a for-profit hospital or going to work for the insurance company is often making more than what they might be able to make in community mental health. The organizations are, limited typically by the Medicaid rates in their state, which, each state kind of sets their own rates. And so there can be a lot of variation in that and, how much the organization can afford to pay even clinicians in some programs that might have a similar degree to clinicians in a different program who have a similar degree. Like the pay might be quite different just based on where is the funding coming from. And it's complicated. It's a complicated, system.
Yeah, there's not a lot of money.
There's
Yeah.
there's not a lot of money. People do not go into community mental health to make their fortune, that is for sure.
Yeah. Yeah. So, Katie, you're in Colorado, right?
Yep.
Um, and there, tell us a little bit about. There's some transparency legislation in Colorado. What's that about?
Yeah, so Colorado is one of the first states in the US to pass pay transparency. And what that it's equal pay, making sure that we're looking at the gender gap and doing the right thing. But that law basically stated that all employers needed to publish their pay ranges. And back in the day, talking about salary was somewhat taboo, right? Like you just didn't do that. And I remember when this came into order, we were thinking, how are we going to prepare for this? And quite frankly, I love it. It shows ranges. I'm sure all of us have had experience where my sister works for this office here and they're making $5 more an hour and we're so far behind. And, we do a lot of compensation surveys. There's so much rich data with compensation, but we're able to literally look up postings with our competitors and we're able to say, oh, yep, this is what they're paying. Do we need to make any kind of changes? Because the market sometimes moves quickly. And I think originally we faced some resistance. I know that there was an actual website where organizations that had big companies wouldn't want to allow remote workers in Colorado because they didn't want to post their jobs. But if I think we're up to now almost 15 states that have that. So we're seeing this more and more, and it's been pretty transformational when it comes to compensation practices.
So, are the salaries posted by person or by job category?
It's by job title. So
Okay.
every position that we post, hey, we've got a clinical director. Here's the minimum. Here's the maximum.
Okay. Yeah. Yeah. You mentioned this in passing, but that, salary is one of those things that is a very sensitive topic. I'm
Yes.
reminded there's an old story about this guy that went in psychoanalytic psychotherapy for like 8 years and talked to his analyst every like twice a week about everything in his life, sometime the therapist said, "Oh, by the way, I didn't, I'm just curious, what do you make a year?" And the guy says, "That's a pretty private question." So it's like even in those cases where we're disclosing everything else, it's like I don't want you to know what I make, it is a sensitive topic for a lot of people. When you guys look at ways in which we can improve the compensation or creative ways to incent certain things. I know pay for performance is one. What things can are on the table that listeners could think about in terms of ways to make the lives of the employees better with or without compensation?
Yeah, I think the first thing when it comes to compensation, it has to be easy to explain. If you have a program that is so confusing and how you calculate this, if leaders can't understand that, how is our staff going to understand that? And so I think it's vital as you're building a compensation program that it's founded with data, right? You're looking at surveys, you're looking at your specific areas and industries. That's first, but then having it in a way that you can train to it, your philosophy is understood all the way down. Because if it's not done that way, that can create confusion. People might see it as unfair. And so I think just being transparent with a process that's simple to explain is probably the foundational effort with a successful plan.
Amanda?
Yeah, I mean, we, definitely, worked very hard to make sure that ours was clear, and it took a lot of administrative burden actually for us to be so transparent with how we got to the numbers we did. I've seen lots of different techniques in this area. I've seen organizations use shift differentials. I've seen folks use um, additional compensation for direct service time versus their administrative time to help encourage clinicians to constantly be thinking about their caseload and caseload management and how do they manage the appointments that they're seeing on a regular basis. I've seen other situations that are more direct service, like getting to a certain threshold with your direct service on a monthly, quarterly, annual basis results in additional compensation for meeting those. I think that all of that, anytime you're talking about incenting for compensation, I think you need to put into place safeguards against staff who are going to be looking out for their best interests and not necessarily the organizations. And often that times that's going to look like additional checks and balances through either the supervisor or other monitoring techniques to make sure that what they are documenting they said that they were doing is what they were actually doing, and everything lines up and tracks, and make sure that you have systems in place to monitor that anytime you're going to incent behavior.
You're not saying that somebody would game the system, are you? That's
I'm saying that humans look out for their best interests often, and sometimes those interests are not aligned to the organization's interests, which gets to the point that anytime you can align the interests of the clinician with the organization's interests, that's a win-win.
yep, yeah. That kind of brings us to the dreaded P word, productivity standards. Uh, how do first of all, do you in your organization, Katie, and in your former organization, Amanda, did you guys have productivity standards? And if so, talk us through how you computed those or calculated those.
Always, right? That could be considered a bad word. And when you think about productivity, you think of either the carrot and incentivizing and rewarding or the stick. So then if you don't meet this, you're going to get in trouble and you might be disciplined. When we looked at incentivizing productivity here at AMHR, there was a lot of work done on the front end with communication. And we looked at billable hours. And quite frankly, our teams did not like that. This is all about money. This isn't about our clients or our patients. What are you doing? I mean, it was very challenging. And basically we looked at their clinical FTE, how many hours they work and how much of that is billable. And no matter how much change management, how many discussions, how many town halls, our engagement scores tanked because it's a different level of accountability. And we're so mission focused. So when somebody thinks that you're taken away from the mission and that you're not doing the right thing, it took a lot of work. But then once it was up and running and people were able to get bonuses and they were able to see this, but not only that, we were able to show access. These graphs that we have that show the number of connections that we've had, it really showed, yeah, this is about serving our community better. But you also have to be flexible, right? So if somebody takes vacation, you have to consider that into the equation. You have to think about, time off or leave of absence, or if somebody is onboarding, it takes some time. And I liked what Amanda was saying. You have to keep the people element in all of these things and making sure that you're doing the right thing.
You used your productivity expectation was a percentage of billable time as a percentage of your total time at work.
Correct. Uh-huh.
Can you share what that percentage is?
Off the top of my head, I can't remember what that is. I want to say 20 to 25 hours probably for somebody that works 40 hours.
Yeah, that's pretty common because you like you said, the balance of that is vacation time. It's,
Uh-huh.
maybe even onboarding, but it's certainly, it's unrealistic to say 40 hours of a 40-hour week is all productivity expectations.
Yep. Correct. Exactly.
How about your folks, Amanda, when you were in operations?
So, so you mentioned the productivity word. So we did not discuss it as productivity. Similar to Katie, I think staff are very sensitive to the idea of productivity and being around money. And so we really stayed focused on direct service, which again, now you are aligning the reasons that people are in the field and they're here to help people. Like that's why people come to work in community mental health. So this is, the metric by which we count how much we are helping is direct service hours. So that's one way that we did it. The number of for us that was mostly tracked by units because that's how our state kind of organized payment. So we had a unit target for each position per month and then one per quarter and then per year, and they were paid out in different ways, but the idea was that you might not be able to make it within a month or 3 months, but like over the course of the year, factoring in vacations or time off or those other things, like you could still get it if you were able to kind of balance that out across the year. So it was very, like I said, it was very complicated and we took on a lot of administrative burden on our side to make it as straightforward and transparent as possible for our staff. But we definitely use direct service targets within the organization.
I had to smile when you both of you were talking about this, and it brought back memories of when I took over the mental health center, and they had a productivity system, but it was a little bit weird, and we had to change it and kind of align it more with kind of like what we were doing. But we had exactly that same pushback. When you mentioned that you could lose providers because they went to for-profit providers that paid better, there's a reason for that, and it's not just the indigent care line. That's not. It's a managerial thing, or you know, so it's something else that other than the reimbursement scheme or something. And
Yes, and the impact of that is ginormous to organizations, right? So, you know, even if a similar community mental health center down the street offers a $500 signing bonus, people will jump ship for the $500 signing bonus. The amount of disruption for the clients and for the organization and the training costs and the churn costs related to that $500 bonus is astronomical. Like, that's how you get to organizations that experience 40% churn annually,
yep.
and that is not efficient. That is not efficient.
Well, and related to that, and kind of segues us into the next section I want to talk about, and is that people will also take managerial jobs to pick up a few more bucks, even though they have no interest at all in management. Have you guys seen that at your place, Katie?
Yeah, we have clinical supervisors, so they're kinda like manager light, where they can dip their toe in it, but it's challenging because people want momentum. They wanna move up, right? They want more money, but when it comes down to leadership, it's hard, and when you're supervising peers now and having crucial conversations, it's a lot, and so we try to have the supervisor route where we're kinda getting the best of both worlds just to see if that's something that they like, and if they do like the leadership components, then we can work on succession planning and moving them up.
Did you guys do anything like that, Amanda? Or yeah,
Yeah, I mean, we had definitely looked at tracks as far as hiring. So, for example, if a person wanted additional responsibilities, we offered opportunities for them to specialize in certain aspects of the job where maybe they had an additional skill set that would offer a little bit of extra money in addition to their role for that additional skill set. Similar to, someone who was bilingual, right? We would pay them an additional amount of money for that additional skill set. That's kind of how we approach it. But I've also seen people who moved into management and then realized this is not for me. This is not for me. And they transitioned back to an individual contributor. And often in those situations, like we tried to keep them at an equivalent pay rate so as not to lose them. Because they did have some additional skills at that point. So, like, it's very nuanced when you get to that point. But I also think that sometimes you end up losing your very best clinicians because sometimes the very best clinicians are actually also interested in being promoted into management, and now you lose them as clinicians, and that's sad too.
I know I inherited a system when I took over the mental health center, and I had clinicians that had gotten in who took over manager jobs solely for the money. They had no interest at it. They weren't good at it. And I said essentially what you guys have done is like, look, if you want to be in management, we will train the heck out of you to be a good manager. But to be a manager, you need to be able to do certain things. Like you got to be ready to fire somebody. You got to be able to do performance reviews. You got to run a P&L because you got a budget now. And probably two-thirds of them said, I don't want to do that. I said, then get back into a clinical supervisor role and we'll move people into those jobs. And that was hard for them, but we had to do the same thing, a parallel track, clinical, you know, climb the clinical ladder, but I don't want to jump into full operations. Or yeah, we'll get you into management and help you learn how to do management.
And I think when they are in management, I have seen some amazing folks who have become amazing leaders because they have walked the walk. They don't just talk the talk, they have their own experience living in the shoes of the folks who are doing the work. And I've seen some really amazing leaders who, even at the director and above level, roll up their sleeves and get back out there and go do the hard work out in the community. And, you know, that is that's leadership, right?
You got people who are chomping at the bit for promotion. And you guys have outlined some really interesting paths here of how to do that. But I mean, organizations, I mean, how, these jobs don't open up. I mean, what do you do in the meantime when you've got, somebody who's saying, I really want to get into management and there aren't any management slots available? I mean, how do you address those kind of challenges?
I mean, I think you look around the organization for other opportunities to develop their skill set so that when there is a position available, they've not only worked on this team, but they've worked in another team that might be similar or slightly adjacent to, or maybe now they work in the housing program. So now they have a better understanding of how the housing piece fits into all of this. So, like, you can move people laterally so that they can kind of round out a very nice skill set that is then poised them and positioned them for leadership when the time is available.
And I think you can do project-based things too. It's like, "We got a project here, can you take the lead on that?" That kinda starts scratching that itch a little bit, and also gets you as their supervisor, gives you a chance to see kinda how they do that, coach them a little bit, you know?
Mhm.
Yeah, project work is huge and having exposure, right? So you lead that and you collaborate with other groups that aren't in your typical department, or maybe you get to showcase what you've learned to the executive team. There's a lot of different ways that
Yeah,
you could
yeah,
stretch assignments.
yeah. My philosophy, I don't know how you guys feel about this, but my philosophy is that there's no such thing as a perfect employee, there's no such thing as a perfect job, but there can be a perfect match of job and employee, and that's what you search for, is
Yes.
is that is that a good mesh? And so, one of the things that we haven't talked about, but I think has some opportunity, we've already seen it with Eleos, that there are technology solutions for some of this stuff. And, I'll talk about the clinician facing stuff in a minute. But Amanda, you mentioned, you got a wait list. I mean, one of the things that we have today that we didn't have then are kind of client facing apps and, those kind of behavioral health things. I'm not too shot up about those because the research on them isn't that great. The adherence rate's not great. But if you have to choose between getting nothing and maybe getting something that can start your engagement, some of these apps that, particularly like, look at the Veterans Administration, they've vetted a whole ton of really good apps. So there are things out there that are effective. But what's your thinking about how technology can help providers with the tsunami that's heading their way?
Because my background is really community mental health, and I've spent the more recent time in like serious mental illness spaces. We're talking about a client population that is indigent. They might not have a cell phone. They might not have the ability to navigate a cell phone. Um, they might be using like a flip phone that just allows them to make a phone call, and that's the extent of their ability to navigate the phone system. So, like, that is where I think, um, as great as technology will be for some populations within behavioral health, there are limitations, and it specifically bumps into community mental health, where in community mental health, those apps are not going to solve the problem of folks who are struggling with really significant mental health issues. You need a human to go to their house and help them do the things that they need to do to stay in the community and out of institutional settings. As far as the clinician goes, I mean, that's really what drew me to Eleos. We were dealing with very high staff turnover. We had very challenging jobs and client populations on our clinical side, and the administrative burden of that documentation was overwhelming and definitely played a part in why people sometimes left the organization. And as a COO at the time, like, I felt that when this was brought to my attention, this is how I was going to justify the ROI. I didn't need it to increase the productivity. I didn't even want to talk about increasing productivity. I really wanted us to focus on how is this going to help us keep one or two staff a year, and that's gonna pay for the product. That's all I needed, and that's the pitch that I made to the CEO at the time. If we just keep 1 or 2 staff from burning out a year, that covers the cost, and we didn't have to do anything. Not to mention a lot of other, like, side benefits that I anticipated, like, allowing clinicians who were providing good service, but but it seemed insignificant compared to the burden of documenting it. And maybe they just didn't document that 8-minute phone call they had with the client, right? And then that's lost revenue for the organization. Or, I mean, there were lots of little ways that I thought, oh, yeah, it's also going to have an impact to productivity because it's going to allow them to capture the services that they were already doing, but maybe not getting credit for. And I think that, I left the organization not far after that launch, but I do think that they had some uplift in productivity, not because they increased the expectations necessarily, but because people were able to capture the services that they were already doing. And you could see it in, like, did they meet their productivity targets and then get bonuses? So when you start paying out more bonuses because more people are hitting the targets, that's an indication that something's going real well from a revenue and billing perspective.
I think anything that we can do to help our clinicians, I mean, these are hard jobs day in and day out. And I mean, how many times have you heard, I love our EMR? It's perfect. It's simple. All these different things. And so like Elios has been such a great partnership because it saves time. And hey, we see your pain points and this is what we want to do to try to help you. And I loved what you said, Amanda. If it just takes one or two people not to be burned out. But yeah, we as leaders need to do everything that we can to try to help our people do their best work in the best way possible.
Yeah. And then, I think, and that, as you said that, Amanda, is like the data I've seen is like cost of turnover is about 30% of salary. It doesn't take a lot of decreasing turnover to make that ROI work. And then, like I think you've heard this, Amanda. We've, other customers of Elios, they have what we've seen is if you don't press the productivity issue with clinicians and just say we're trying to make your life better, productivity goes up oftentimes because they now have bandwidth and they could absorb another client if you ask them to. But if you don't make that a condition of now you've got Elios, so we're going to ramp it up by 10%. It's like let it happen organically because it oftentimes does. And what advice do you have for others who are grappling with this kind of compensation? But it's not just compensation. There's other things besides money that makes employees sticky to stay in your organization. What advice would you have for others? Let's start with Katie.
I think having a transparent organization is huge. There have been so many changes this year, and as we're trying to define what that means or what that impact is, we have quarterly town halls. We'll have special employee meetings and communication. We don't know all the answers, but again, I think people are scared or they're unnerved not knowing what the future is going to be. And so for us, having consistent communication and in different forms. So not only just the town halls, but every Friday, our CEO sends updates. We have cascaded communication with our directors and our managers. But even if you don't know all the answers, here's what we do know, and here's how that is. And we really saw a lot of comments on our engagement survey that our team, it's been a bumpy ride, and there's been a lot of changes, but they like knowing that they're going to get updates every week from us, and that's been very helpful.
I do not have a magic bullet for this. I mean, it's gonna be hard. It's gonna be hard and my heart breaks. As I think about what would I be focused on, I think that I would continue to be focused on, um, the things that you can impact. So, you won't be able to impact all of the legislative stuff that's coming down, although you will try to advocate, and you should advocate. And then I think continuing to invest in your staff, and it's completely separate in some ways from the chaos that is happening with payers. You will always have cost of turnover. So whatever you can do to reduce those costs, because the dollar that you save is just as valuable as the dollar that you earn or that you bring in. Whatever ways that you can reduce the costs, not in salary, because I think you're gonna yeah, that's not what I would advocate for. We need to pay our staff as much as we can. They are the reason that you can continue to serve clients. Yeah, continuing to invest in how you alleviate burden for clinicians, I think is always going to be a winning strategy. even when you don't have control of the rest of the chaos that's going on.
Yeah, if anything, I think a lot of um, the solutions that Eleos offers are perfectly positioned to help organizations, both in terms of the documentation burden, the compliance product to make sure you're billing at once and not getting hammered. I mean, you want to keep every dollar you're owed. You've got to bring your staff in as partners on this. With that, I want to thank both of you, Katie Weihe, Amanda Rankin, and also want to thank Brooke Andrus, our producer, and Harrison Bach, our AV manager, for helping us put this together. And with that, we will call an end to this episode of No Notes.
Thanks, Denny.
Thank you.